name's Winifred Beevers. I'm a registered music therapist working in Melbourne, Victoria, Australia. Been a music therapist for a long time. My family bounced around between the UK, Papua New Guinea and Australia, finally settling in Australia when I was about 10 or 11. So my accent, my voice is a little bit weird. It's a mixture of some Australian sounds and some English sounds, mixture of some Queensland sounds and some Victorian sounds. I've been a music therapist for a long time. I have worked throughout my career with older adults, and I've worked across the fields, both inpatient, acute, subacute and residential and in community care, across the areas of aged mental health, palliative care, general medical care and people with cognition loss. And as part of one of my jobs, I worked in a hospital where there was a general medical unit for older adults. It was called the Geriatric Evaluation Management Unit. It was in the GEM unit that there was an exercise group, and I was asked to give some feedback on the music that they were using for exercises because they'd got some feedback from some of the patients that they didn't like the music. So I said, sure, go along. I went along and listened and joined in, and it was talkback radio that they were using. And it really didn't work at all. It was actually counterproductive to the group. So I sat down with the exercise physiologist and the assistant who was running the group, and I said, I reckon we can have some fun here. We can do something interesting here. And so we agreed that for 12 weeks we would do a quality improvement project, we'd set it up properly, and that we would assess the clients as they came in and see what kind of music they liked. I would find it for them, I would make suggestions, they would decide yes or no. The exercise physiologist would actually give the directions for the group and set the pace and tell me to slow down, speed up, that sort of thing. And at the end of 12 weeks, I went on holiday. Came back from holiday, we'd written it up, we'd handed it to our supervisors, walked in through the door, and it was like, you have to do that group, you have got to keep doing the group, you've got to keep doing the exercise group with the music. And the overwhelming response from the exercise physiologists and the physios was that whilst the music was playing, whilst it was live, this was really interesting, the range of movement that the clients would use went from being a little bit to being a lot. And instead of being able to do 8, 9 or maybe 10 repetitions of the music, they would keep going until the music stopped. So 10 repetitions of an exercise or a movement, they would keep going until the music stopped. So instead of doing 1, 2, 3, 4, right, all the way up to 10, they would just keep going for the length of the piece of music. Now that might be 15, that might be 20 repetitions. So the patients were exercising for longer with more effort, but not feeling tired and deflated at the end of the session. They were feeling quite energetic and quite energized, full of beans, raring to go. Out of that QI project, that expanded into a research project, and the hospital system I worked for had a very close relationship with La Trobe University. So I went to La Trobe University and started doing a research master's part-time. And as happens, the minute you start doing any kind of research, it changes. The supervisor I ended up with had quite an interest in Parkinson's disease. Her name is Professor Meg Morris, and if you're interested in Parkinson's, anything that she touches is just gold to listen to. So I ended up doing research on the music that was used for a dance exercise intervention, and it was pre-recorded, it wasn't live, but I did a musicology analysis of the music. And I worked out from the musicology analysis what range of tempos was best for people with Parkinson's, what kind of music worked really well, and I looked at what it was that linked the music that worked really well. So the phrasing, the harmonies, the modalities, the keys, did it modulate, did it not modulate, the complexity of the rhythms and the complexity of the melodies, and how familiar the music was to the people who were listening and doing the exercise. That got published and submitted a couple of years ago, a few years ago, and I'm still doing it. I'm still running groups and still running exercise groups. And sometimes I'm doing it all on my own, and sometimes I do it in a more formal setting. structured setting with other allied health professionals. But out of that, yeah, that's how I ended up here, incredibly passionate about using music to support exercise, and that's what I'm going to be talking about in this tutorial. These tutorials are going to talk about music and music for exercise and how you use music to support exercise. I'll talk a little bit about the people I've worked with, their diagnoses, the principal disorders I've seen, be it stroke or a neurological disorder or complications after cardiac issues. I'll talk a bit about the symptoms and the resulting disability and why those people are referred to an exercise group. I'm going to talk about the music that you use in an exercise group, how to run the group, how to change the music to support the exercise and make the exercise interesting and to motivate people to not only attend but to participate to their fullest. Talk about the different movements that you'll see people do in exercise groups, how you time the movement and how from that you predict what music will fit into it, how you modify the music to make sure it does fit and sounds good. And then I'll talk about how important the downbeat and the rhythm of the music is and how the melody comes into play as well. I'll talk about repertoire and how to select repertoire. And finally, I'll talk about the equipment I use.